Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm covering part 5 of diabetes. On this video, I'm going to go over more patient teaching, and we're going to cover the difference between diabetic ketoacidosis and Hhs and Ks. So let's get started. Let's take a look at this table 4815. Oh wait, before I get started, I gotta get my plug in. If you haven't done so already, guys, go to my social media platforms. Go check me out on TikTok, Instagram, Facebook. During the week, I go over questions. So if you don't want to wait till Sunday, 1 p.m. Eastern Standard Time, which is when I release my videos on YouTube, you can catch me during the week with a different set of questions where I go over and I explain the rationales. Also, I also have, I can't speak. I also have audio lessons available on my website, nexusnursinginstitute.com. Now we can get started. All right, instructions for patients with diabetes. Let me make this a little bit bigger so you guys can see. I'm not going to cover everything, guys. You see it, press pause so you can read everything. I'm just going to go over some. You're going to teach a patient to record and write down those results that they have so that when they come into the doctor's office, when they come in to see the nurse practitioner, when they come in to see their healthcare provider, we can actually look and see what their blood sugars, been looking like, okay? Teach them to take their insulin consistently, especially when they're sick. Remember, when you're sick, your body's stressed. What happens when your body's stressed? It shoots out more sugar. So the patient's glucose will be higher during times of stress. So they need to take that insulin consistently, especially when they're sick. Obtain hemoglobin A1C test every 3 to 6 months as an indicator of long-term blood glucose levels. Remember that hemoglobin A1C shows us if what we're doing for that patient right now, is it working? Is that patient being compliant? Because it gives us a picture of what that patient's blood glucose has looked like consistently the past 90 days. They can't trick us with that hemoglobin A1C. Teach them to carry a form of rapid acting glucose at all times. Why? What kills you faster? Hypoglycemia or hyperglycemia? Hypoglycemia. When the patient's blood sugar is high and they have hyperglycemia, there are so many different mechanisms that happen, and we'll talk about that in DKA, but the body's trying to save itself. But when that blood sugar is low, there is nothing that the body can do because it has no energy to try to help you because the blood sugar is low. So the patient will bottom out like that. So you're going to teach them to make sure they have a form of rapid acting, something that will bring up their blood sugar immediately, okay? Food. Oh, I skipped something. That's just joking. Let's go to exercise. Remember that exercise will usually lower your blood sugar. Usually. So the patient needs to keep that in mind. Before they exercise, they need to take their blood sugar, right? And then during exercise, if they're feeling like they're getting weak, they need to take their blood sugar again. Why? Because exercise most often does what? It lowers the patient's blood sugar. And what are we more worried about, hypo or hyper? Hypo. We want to make sure that their blood sugar doesn't drop too low. So you're going to teach them that. Food, choose foods low in saturated and trans fat. Teach them to make sure that they know their cholesterol levels. Limit the amount of alcohol that you drink. Be aware that excessive amounts of alcohol, that's why we're telling them to limit it. Excessive amounts of alcohol can lead to unpredictable low blood glucose reactions. Avoid fad diets. That is on HESI, it's on ATI, it's on NCLEX. That is very important. The patient that's diabetic, the patient that's on insulin, they're not the ones who need to be on the, the South Beach diet or the Atkins diet or whatever fad diet is out there. They need to consistently eat healthy foods. Limit regular soda and fruit juice. Other guidelines. I'm scared to touch my camera because I broke it. Obtain an annual eye examination. Why? We know that diabetes is the #1 cause of blindness here in the US. Obtain annual urine monitoring for protein. Why are we doing that? Remember, your kidneys are the gatekeepers. Proteins are very large. they should not be getting past the kidneys. So, we're seeing protein in the urine. We're going to start looking at the kidney function, because we know among the list of things that diabetes affects, the kidneys are on top of that list. Teach a patient to examine their feet at home, and I'm going to go more into that when I talk about foot care. Teach them to wear comfortable, well-fitting shoes. And this is important, guys. They can't wear shoes that are too big, because if the shoes are too big, pretend that this is the shoe and this is the person's foot, right? If the shoe's too big, while they're walking, their feet is just going to be sliding back and forth, back and forth, back and forth. And that sliding back and forth can cause an opening in the skin, right? Decreased tissue integrity, a perfect opening for bacteria to set in. And before you know it, the patient's got to get their lower extremity chopped off because of an infection that just won't heal. So it's very important. They can't wear shoes that are too big, but they can't wear shoes that are too tight either, because if the shoes are too tight and there's no room at all for the toes or anything, that patient may get a bunion. They may get, what's it called? I forgot. They can get a corn, right? And those, excuse me, can also decrease the skin integrity on the patient's lower extremity. So the shoes have to fit properly, not too big, not too small. Stay away from thong sandals. Why? Thong sandals are the sandals where the strap is right here between the two toes. So as the patient's walking, you got the strap just rubbing up and down between those two toes, which will decrease that tissue integrity. Skin opens up, bacteria sets in. Before you know it, their foot has to be chopped off because the wound will not heal. Teach them to always carry identification that says they have diabetes, a medic alert bracelet, have a yearly, let me tell you something. Patients with chronic conditions, they need to be the first ones in line every season getting their flu vaccine. They need to be the first one, and yes, I said it, getting their COVID vaccine. Patients with getting pneumonia vaccine. Patients with chronic conditions, diabetes, patients with sickle cell, patient with chronic conditions that can't afford to be sick, they need to get their vaccinations. Those vaccinations are what? Primary prevention measures, vaccinations and education. So they need to be getting their flu vaccine, teach them to quit smoking if they're already a smoker. And if they're not a smoker, teach them not to start. Quit or never start smoking cigarettes or using nicotine products. Avoid applying heat or cold directly to your feet. Why? Patients who are diabetic are at way higher risk for diabetic neuropathy. They cannot feel the heat. They cannot feel the cold. So all that heat on the skin, they can get burned and not even realize it. All that cold on the skin, they can get, what do you call, what's that word in English? Something frost. Not cold frost. Is that what you guys say, cold frost? I don't know. It's something frost. It's not coming to me. But anyway, what happens is it's so cold and it's been on the skin for so long, those cells start to die and the tissues start to die. So either end of the spectrum, we don't want to happen. It's not cold frost. When? No. In the comments, somebody tell me what word, what phrase I'm thinking of. Something frost, but it's not coming to me. Avoid going barefoot. Why? Think about it. Frostbite. I think that's the word I was looking for. I might be wrong. But anyway, avoid going barefoot. Remember, the patient's going to have diabetic neuropathy. Their feeling is decreased in the lower extremity. If they step on a pebble, they step on something sharp that cuts open their skin, they may not feel it. And so for days, there's been dirt, there's been bacteria, there's been pathogens in that cut, and it's just festering. Okay. So we always want their feet to be protected. Look at this. You want to keep the skin moisturized by applying cream to surfaces of the feet. Why? I want you to think about it. If that foot is dry, they got cracks all over the heel, that foot is dry as I don't know what do you think is going to happen? It's going to break open because it's so dry. And as soon as it breaks open, bacteria and all types of pathogens are going to creep in. So we want to keep that foot moisturized so it doesn't crack. So there's no entranceway for the bacteria. But this is important, guys. Look at what it says. But not between the toes. And honey, If there was anything I could ever tell you that has been seen on NCLEX a million times, it's this. You need to know this. So yes, you want to keep the feet moisturized, but not between the toes. And I want you to think about it. So pretend these are toes. This is the big toe. This is the second toe. Between the toes, you keep here moisturized. What's going to happen? Maceration. And that skin's going to open up. Plus, between the toes, there's no circulation going on. There's no air going on. Bacteria loves moist, dark environments. Don't you think that would be a perfect medium for bacteria to start to grow? Yeah. So we want to keep the feet moisturized, but not between the toes. Very important. Don't say I didn't warn you. All right, let's move on to diabetic ketoacidosis. Now, if you watch my part 1, 2, 3, 4, you know who gets DK more, type 1 or type 2? Type 1. Why? Because DKA is so severe. What happens in DKA, patient only goes in DKA when that blood sugar is so high because the pancreas isn't doing anything, nothing at all. And between type 1 and type 2, who's more likely to have that shot pancreas is not doing anything to produce any insulin to help that patient live? Your type 1. It can happen in type 2. The patient can be type 2 so bad that that pancreas is just giving up. Right? And so the pancreas is not shooting out enough insulin to maintain survival. So yes, patients who are type 2 diabetics, they can go into DKA, but more often we see this in our type 1s. Let's talk about it. It says diabetic ketoacidosis, that's our DKA. It's caused by a profound, that means a whole lot, not a little bit, a whole lot, a profound deficiency of insulin, an extreme deficiency of insulin. So not just, oh, you know, the patient's missing a little bit of insulin. No, that patient's missing a lot of insulin, okay? A profound deficiency of insulin. And it's characterized by hyperglycemia, too much sugar in the blood, ketosis. Remember, I told you about that ketosis, guys, when there's no, the tissues aren't getting the sugar because the sugar's stuck in the blood. So it starts breaking down the patient's own fat, the patient's own protein. And that byproduct, that's the ketosis that you're seeing, okay? The acidosis and dehydration. Because remember, as that blood sugar gets so high, the body tries to survive, okay? So the body tries to get rid of all that sugar. How? By getting rid of it in the urine. So the patient's urinating, dehydration. It's most likely to occur in people with type 1 diabetes, but it can be seen in people with type 2 diabetes if their condition is severe enough, if that pancreas is stressed enough, because remember, the pancreas is responsible for producing and shooting out that insulin. Okay, precipitating factors include, so what can bring on DKA? Let me bring this up for you guys to see. My throat's getting dry. I've been sick for a couple of weeks, so I'm trying to get as many vitamins as I can. Vitamins, minerals, probiotics, okay. Precipitating factors include illness and infection. And we know that because we know when the body's stressed by illness, by infection, it makes more, shoots out more sugar, more glucose. Why? Because glucose gives you energy. You need energy to fight off the infection. It makes sense. Inadequate insulin dosage. So the patient's taking insulin, but they're not taking enough. That insulin that they're getting is way too low. That can throw them into DK if it's bad enough. Undiagnosed type 1 diabetes. So the patient has type 1 diabetes, but hasn't been diagnosed. So they're not making that insulin. So the blood sugar is just going up and up and up and up and up. The tissues are being starved and starved and starved for glucose until eventually it starts feeding off of that patient's fat and then protein, right? Where was I? Poor self-management and neglect. All of these basically boil down to that body not having enough insulin. The causes are different, but that's what it boils down to. When the circulating supply of insulin is insufficient, when there's not enough insulin, glucose cannot be properly used for energy because glucose is what gives you energy. That's why when you're sick, your body shoots out more glucose to give you energy to fight off that infection. The body compensates, look at this, guys, by breaking down fat stores as a secondary source of fuel. So your tissues are starving for glucose, but it can't get the glucose because the glucose is stuck in the blood. So your body's like, okay, what are we going to do? And the body's like, well, we need this glucose somewhere. We need to get this energy somewhere. Let's start feeding off of the fat. And the byproduct of that fat broken down, those are the ketones that we're dealing with here. Let's keep going. Ketones are acidic byproducts of fat metabolism. And this can occur as this can cause a serious problem when they become excessive in the blood. Make this bigger for you. Ketonuria, having ketones in the urine. Ketonuria is a process that occurs when ketone bodies are excreted in the urine. During this process, electrolytes become depleted. So they go down, they're low. They become depleted as cations and eliminated along with the amniotic ketones in an attempt to maintain electrical neutrality. That says a lot, guys. So during this process, when those ketones are going in the blood and they're going to come out in the urine, look what it says. The electrolytes become low, they become depleted. Look why those electrolytes drop. As cations are eliminated along with the amniotic ketones, because always your body's trying to maintain homeostasis. So it's trying to maintain that electrical neutrality. So not only is that patient at risk for dehydration, they're getting rid of all of this glucose in the urine. That's why they're doing all that urination. They're at risk for dehydration, but also electrolyte imbalance, because those electrolytes are saying bye-bye as well. Okay, this is important. Make sure you know the difference. That's why I wrote right here, know the difference. Comparison between hyper and hypo. You have to be able to recognize the differences between hyper and hypoglycemia, because you will get a test question and they will not tell you what that patient's blood glucose is. And you're expected to know what's going on with that patient. So let's look at the differences. Signs of hyper, and remember what I said. If the patient's hot and dry, their sugar's too high. If they're cool and clammy, they need some candy. Manifestations for hyperglycemia, the sugar's high. Obviously, the blood sugar is going to be elevated, increase in urination. Why? Because they're trying to get rid of all of that glucose in the urine. Increased appetite. Why? That blood sugar is so high, the tissues are starving for energy that they get from the glucose, right? So your body's trying to survive. So what does your body do? Make you hungry, trying to eat more food to get more glucose. But the problem is you have glucose is just stuck in the blood and not going to the tissues and cells where they belong. Weakness, fatigue, blurred vision, headache, glycosuria, seeing that glucose in the urine, nausea, vomiting, abdominal cramps, and a progression of DKA or HHS. I still call it HH and KS. This book calls it HHS. It's the same thing. Okay, this DKA we see more in type 1, HHS, or if your book calls it HH and KS, we see those more in type 2 diabetes. Now look at hypoglycemia, when the patient's blood sugar is too low. Remember, the blood sugar is supposed to be 70 to 110. Give me a second, guys. Hypoglycemia, blood sugar lower than 70. Cold, clammy skin. That word clammy means like wet, they're sweating. Feeling numbness in the fingers or toes. Rapid heartbeat, tachycardia. Emotional changes, headache. Let's go back to emotional changes. You ever been hangry? You're so hungry, you are angry, you're mean to anybody that looks your way? Yeah. Faintness, dizziness, hunger, changes in vision, seizure, coma. Treatment. So for hyperglycemia, if the patient's too high, you're going to get medical care, right? Continue the diabetes medications prescribed, check their blood glucose, check their urine for ketones. You want to see how bad it is. Teach them to drink plenty of fluids on an hourly basis. Why? We want to avoid what? Dehydration. Remember, with hyperglycemia, dehydration is a risk that can happen. And of course, teach them to call their healthcare provider right away. For hypoglycemia, if the blood sugar is too low, follow the rule of 15. I'll go over that with you in a second. And see table 48-19 for hypoglycemia. Okay, let's go over that right now, and then I'll come back to this. So let's go to the rule of 15 first. Now remember, this is for patients that are hypoglycemic. Page 1146. Okay. Here's oh, someone asked me in the comment section what book this is. Do I have the front of this book? I don't think I do. On my videos for diabetes, on the part 1, at the beginning of the video, I showed you guys what book this was. You can go back to that video. What I will do after I post this video, I'm gonna go find the book. I wonder if this is it. Hold on a second, guys. Let me see if this is it. Page 1146. Is that then? Is that the same book? Oh, no, that's not it. No. I'll find it. I'll find the book. I have like 3 books of everything. I'll find it and then I'll put in the comment section for you. All right. So rule of 15 for hypoglycemia. A blood glucose of less than 70 is treated by ingesting 15 grams of a simple fast-acting carb. And they give you examples, guys. What would be an example of 15 grams of a fast-acting, something that's going to bring up your blood sugar right away? Look at this. 4 to 6 ounces of fruit juice or regular soft drink. Okay, so 15 grams of that. Commercial products such as gels or tablets that contain specific amounts of glucose are convenient for carrying in a purse or pocket to be used in situations. So the first thing you're going to do is take 15 grams of a fast acting, something that has glucose in it that will bring up your blood sugar immediately, right? After you do that, you're going to recheck the blood glucose in 15 minutes. Oh, let me move this. There we go. You're going to recheck the blood glucose in 15 minutes. You need to give it a little bit of time to bring up that blood sugar, right? So you're going to check the blood glucose in 15 minutes. And then it says, if the value is still less than 70, ingest 15 grams more of carbs and then recheck the glucose in another 15 minutes. So that's why it's called rule of 15. You're going to take 15 grams of a rapid acting carb, check that glucose in 15 minutes. And if it's still less than 15, take another 15 grams, then check again in 15 minutes. So you've done it twice now. If no significant improvement occurs after 2 to 3 doses of the 15 grams of simple carbs, call your healthcare provider. After an acute episode of hypoglycemia, the patient ingests a complex carb after the recovery to prevent repeat hypoglycemia. That's actually on NCLEX. I don't know why I didn't put anything there. Let me explain that to you. Remember, that rapid acting carb is going to bring up your blood glucose, yes, but it's going to bring it back down. So what you want to do afterwards, guys, you want to eat a complex carb like a ham and cheese sandwich to keep that blood glucose up instead of that patient crashing again. So that's what they're talking about. So now you know the rule of 15. And now you know after that you've taken that rapid acting glucose, you want to take a complex carb just to make sure that the patient doesn't crash, that we can keep them at that level until we can get them some help, okay? All right, so that's our rule of 15. And next is See table 48-19 for treatment of hypoglycemia. 48-19. Okay, that's actually, that is a whole lot that we're going to cover when we get to hypoglycemia, because hypoglycemia is going to be a video on its own. So we'll cover that when we get there, but you guys know the rule of 15. We'll cover this on the next video because there's no way I'm going to get to that today. Preventative measures. For hyperglycemia, how can we prevent that from happening? Teach a patient to take the prescribed dose of medication at the proper time, accurately administer the insulin or the oral anti-diabetic agent, teach them to check their blood sugar routinely. This is important. Follow sick day rules when ill. We're going to talk about sick day rules, but remember, when the patient's sick, their blood sugar, we expect the blood sugar to be higher than normal. So there are certain rules that we're going to teach that patient. I'll go over that with you guys. We're going to teach them to make healthy choices and to carry identification. So if they pass out or something happens, people can know that they're diabetic or they're insulin dependent. For hypoglycemia, again, teach them to take their medications at the correct time. We're going to talk about those types of medications when we get to the hypoglycemia video. Accurately administer insulin, non-insulin, their oral anti-diabetic agents. They need to take it properly, because if they take too much, what's going to happen? Hypoglycemia. That's what we're trying to prevent, guys. Teach them to eat adequate food intake, especially when they're going to exercise, because we know that for the most case, exercise lowers blood sugar. So what do you think happens if a patient doesn't eat, they don't take a carb, they don't have any glucose, and then they go exercise? They're going to have hypoglycemia. We want to avoid this. Teach them the signs and symptoms of hypoglycemia to recognize it early. Carry simple carbs with them. So if they have the headache, they feel they're getting hangry, they have those signs and symptoms, they can go ahead and take a simple carb. Check their blood sugar routinely. And again, make sure they carry diabetes identification. Insulin deficiency impairs protein synthesis and causes excessive protein degradation. Not having enough insulin, not making enough insulin, causes what to start breaking down? That protein. Insulin deficiency also stimulates the production of glucose from amino acids from those proteins that are being broken down in the liver, and it leads to further hyperglycemia. So it's like a horrible revolving door. Because of the deficiency of insulin, the additional glucose cannot be used, and the blood glucose level goes even higher, as adding to osmotic diuresis. If not treated, the patient will develop severe depletion of, look at these electrolytes: sodium, potassium, chloride, magnesium, phosphate. They're all going with the urine. Vomiting caused by acidosis results in more fluid and electrolyte losses. So not only is the patient losing all these electrolytes and all these fluids in the urine because it's trying to get rid of the sugar, now it's coming up the other way. Eventually, hypovolemia, not having enough fluid volume, followed by shock. Guess what? Those organs start to break down when the patient doesn't have enough fluid volume, will ensue. The kidney shut down, which may eventually occur from hypovolemic shock. Do you guys know when the patient has hypovolemia, when a patient's blood pressure is too low, one of the very first organs to shut down on you is going to be the kidneys? Why? Your body's trying to survive no matter what. So the kidneys shut down to hold on to the little bit of fluid you have left. And so you'll start to see urine output go down. BUN and creatinine go up. Renal failure, which may eventually occur from hypovolemic shock, causes the retention of ketones, and glucose, and the acidosis progresses. So those kidneys start to shut down. The patient who was losing glucose in the urine is no longer losing glucose in the urine because those kidneys shut down. So they're holding on to the urine, but they're also holding on to what? Those ketones. And we already learned that those ketones are dangerous in the bloodstream. Untreated, the patient becomes comatose as a result of dehydration, electrolyte imbalance, and acidosis. If the condition's not treated, that patient's going to die. No way around it. So let's talk about signs and symptoms, clinical manifestations of diabetic ketoacidosis. Dehydration. Dehydration occurs as in DKA with manifestations of poor skin turgor. You know, when you check that patient's skin, it's supposed to be less than 3, right? It's not supposed to 10. It's not supposed to be more than 3. So we're going to see poor skin turgor, dry mucous membranes. Instead of those mucous membranes being nice and moist, they're going to be dry. Heart rate's going to go up. Why? When the heart's going to recognize, okay, something's going on. Let me go ahead and try to push more minerals, more electrolytes, more oxygen that's in the blood. How am I going to do that? By increasing my heart rate so I can get it to the tissue. So you're going to see that heart rate go up. And that's also what happens, guys, in shock. Those kidneys start to shut down. That heart says, whoa, I don't know what's going on, but I see the kidneys acting crazy over here. I see the pancreas is acting crazy. All of these organs are starting to shut down. Let me get more oxygen, more vitamins, more nutrients, all the good stuff that these organs need that are shutting down on me. Let me get it to them so I can help. So it increases the heart rate because it's trying to push out the blood that's carrying all these nutrients and all this good stuff. So that's why you see that tachycardia, right? Orthostatic hypotension, because even though we see that heart rate going up, that blood pressure is doing what? Going down, especially as they move or try to get up. Why? Think about what's happening, guys. Those kidneys are shutting down. Patients are going to have orthostatic hypotension. Early symptoms include a lethargy. We know lethargy, guys, when they're not with it. You're like, hey, wake up. What's going on with you? And they're just not with it. Okay. Lethargy. They're slow. Weakness. As the patient becomes severely dehydrated, the skin becomes dry and loose, the eyes become soft and sunken. Abdominal pain can be present and accompanied by anorexia, they don't want to eat, nausea, vomiting. Kussmaul's respiration, those are the deep, rapid breathing that's associated with dyspnea. Kussmaul respirations are the body's attempt to reverse metabolic acidosis through exhalation of excess CO2. Let me explain that to you. So that patient's going through diabetic ketoacidosis. They got all these ketones floating in the bloodstream. Remember, ketones are what? Acidic. Diabetic ketoacidosis. It's acidic. If you guys watched, I forgot the name of the video I did, but I did a video on this. I think it was called Fluid and Electrolytes, but I don't remember. But anyway, I did a video where I was explaining when the patient has too much acid, who's going to try to help? The lungs. What are the lungs going to do? The lungs can either speed up your breathing or slow down the breathing. When that patient has too much acid, you want to know what the lungs are going to do? Speed up the breathing because it's trying to shoot out the acid. What's acidic? Carbon dioxide, or if you want to remember, say carbon diacid. So you can remember that carbon dioxide is acidic. So what happens when the patient is in an acidic state because of all of those ketones, they have ketoacidosis, patient breathing starts like this because they're blowing off all of that carbon dioxide, which is what? Acidic. The patient's trying to maintain homeostasis, is trying to bring them back into balance. So we're going to see the body's attempt to bring them back into balance is going to be those Kussmaul's respirations right here. Look at what it says. The Kussmaul respirations are the body's attempt to reverse the metabolic acidosis through exhalation of excess carbon dioxide. Metabolic acidosis, the kidneys. The kidneys are in trouble. Who's the only organ that can help? Who's the only guy that can help when the kidneys are in trouble? The lungs. Just like the only organ that can help when the lungs are in trouble are the kidneys. So metabolic acidosis, where those kidneys are in trouble, the lungs are going to try to help. The lungs are going to try to compensate by Kussmaul respirations, by getting rid of the CO2 to decrease the acid level. Acetone is noted on the breath as a sweet, fruity odor. Very important. You see, I put a star next to it. Laboratory findings include the blood glucose greater than or equal to 250. Normal blood glucose, guys, supposed to be 70 to 110. This patient's in 250. Okay. Arterial blood pH less than 7.30. Remember, your normal pH is what? 7.35 to 7.45. This is less than 7.30. So absolutely, that's acidic. Your serum bicarb, that's your HCO3. Your serum bicarb level less than 16 and moderate to large ketones in the urine or serum. I'm not going to go over this yet because this is going over the difference between your diabetic ketoacidosis and your HHS, and I haven't even touched HHS yet. So let's just hold on for a second. Let's keep moving. Because fluid imbalance is potentially life-threatening, the primary goal therapy is to establish IV access and begin fluid electrolyte replacement. That is going to be a priority for you, because once those kidneys and the other organs start shutting down, that patient's in trouble. So we need to get fluids in them, and we're giving them fluids. Look at what I wrote here. We're giving fluids hard and we're giving fluids fast. We're kind of treating them like a burn patient. Just like those burn patients go through severe dehydration, we need to get fluids in them hard and fast. Same thing with DKA. Okay? Typically, an infusion of half normal saline or normal saline at a rate to restore urine output of 3 to 60 milliliters per hour, and we want to raise blood pressure. To raise blood pressure constitutes the initial fluid therapy regimen. We're trying to get that blood pressure up, and we're trying to get the kidneys functioning again. How do we know that the kidneys are starting to do a little bit better? We see the urine output start to go up. Okay. Remember, we want to see at a minimum 30 mLs per hour, right? So when we start to see the urine output start to go up, we're like, okay, kidneys are getting better. When blood glucose levels approach 250, this sounds crazy, but I'm going to explain to you why, guys. When the blood glucose levels approach 250, we're going to add 5 to 10% of dextrose, of sugar, to the blood, to the fluid regimen. Look at this, to prevent hypoglycemia and sudden drop in glucose. Why? That can cause the patient to have cerebral edema. It can cause them to have seizures. We can't afford for their blood sugar to drop too quickly. So yes, we want their blood sugar to drop. So let's say their blood sugar was, and I've seen it, 500, 400, the blood sugar was high, 600, right? And we get it to go down. It's going down, it's going down. Once we get down to that 250, we're going to add some dextrose. Because if that blood sugar drops too fast, look at what can happen, cerebral edema and all the complications that come with cerebral edema. So that's important for you guys to know. You want to obtain the serum potassium level before starting insulin. Look at what this says. If the patient is hypokalemic, by the way, guys, remember a potassium range is 3.5 to 5, very narrow therapeutic range. Look what it says. If the patient is hypokalemic, which means that potassium is less than 3.5, insulin administration will further decrease the potassium levels, making early potassium replacement essential. This is important. Don't lose what this just said, guys. So before you start giving the insulin, you want to look at their potassium. Make sure that that potassium is within range, because if the potassium's low, if the potassium's already low and you give them insulin, look at what's going to happen. If the patient's hypokalemic, insulin administration will further decrease the potassium. It's going to make the potassium drop even lower, making you have to give the potassium, give them replacement potassium sooner. That's not a problem you want to have to deal with when you're dealing with DKA. IV insulin administration therapy is directed towards correcting the hyperglycemia and hyperketonemia. We're trying to get those ketones out of the bloodstream. Insulin is immediately started at 0.1 units per kilograms per hour by continuous infusion. And you better believe that infusion is going to be on a pump. It's important to prevent rapid drops in serum glucose to avoid cerebral edema. That's interesting, because didn't we just see that up here. So they said it to us here, and now we're seeing it here. Remember what I told you guys, when you're studying and you're seeing the same information more than once, you better take note of it. That means it's important. That means you're probably going to see it on an exam somewhere. A blood glucose reduction of 36 to 54 milligrams per deciliter per hour, 2 to 3 mmol per liter per hour will avoid these complications. These numbers, guys, I've never seen it on the test. I'm not saying you don't have to know it. I'm just saying I've never seen it as a test question. So if you're like me and you're not really good with numbers, don't beat yourself about it, okay? Insulin allows water and potassium to enter the cell along with glucose and can lead to a depletion of vascular volume and look, hypokalemia. That's about the second or third time we've seen the connection of insulin and the potassium being low. So monitor the patient's fluid balance and potassium levels when they're getting this insulin. Okay, that is our DKA. Now let's go into HH and KS, or this book says HHS, so let's call it HHS. Just like DKA was, we see that more in type 1, this HHS we see more in type 2. So let's look at the difference. What's going on with HHS? Just like DKA, HHS is also life-threatening. It's a life-threatening syndrome that can occur in the patient with diabetes. Look at this, who is able to produce enough insulin to prevent DKA, because remember, DKA is the worst. So they're able to make enough insulin to prevent DKA, but not enough to prevent severe hyperglycemia, osmotic diuresis, and extracellular fluid depletion. So the pancreas is making enough insulin, it's providing enough insulin so that the patient doesn't go into DKA, but not enough insulin to prevent them from having high blood sugar, to prevent them from having the excessive urination where the body's trying to get rid of the sugar in the urine, or to prevent them from what? Going into dehydration. It often occurs in patients over 60 with what type of diabetes? Type 2. HHS is often related to impaired thirst sensation and or functional inability to replace fluids. Remember, this patient's at high risk for dehydration. There's usually a history of inadequate fluid intake. Let me stop right there. What is something we know about the geriatric population? They lose their sense of thirst. Remember, that's why you have to always remind them and make sure your CNAs and your PCT remind them to keep taking sips of water, because they'll just forget they don't have that sense of thirst. So we see this more in the patients who are not drinking enough fluids. Increasing mental depression and polyuria. All that urination is going to cause them to become dehydrated. The main difference between HHS and DKA is that the patient with HHS usually has enough circulating insulin that ketoacidosis does not occur. They said that to us here, and then we saw it again up here. You think that's important to know? Absolutely. The author's not telling you the same thing 2, 3, 4 times just for the heck of it. Because HHS produces fewer symptoms in the earlier stages, blood glucose levels can climb quite high before the problem is even recognized. You guys see that? The higher blood glucose levels increase serum osmolality and produce more severe neurological manifestations. We're going to see some CNS changes, such as somnolence. This patient, they used to always be so talky, so bubbly, and all of a sudden you're blah. Coma, seizures, hemiparesis, and aphasia. Since these manifestations resemble stroke, immediate determination of the glucose level is critical for correct diagnosis and treatment. Why? Because time is of the essence. Laboratory values in HHS include blood glucose level greater than 600 and a marked increase in the serum osmolality. When they say osmolality, guys, I want you to think of how many solutes. Okay, when they say osmolality, that's what I want you to think about, the solutes. So serum osmolality, how much solutes in the serum. Ketone bodies are absent or minimal in both the blood and urine. Remember, the ketone bodies, that's what differentiates your DKA and your HHS. We see those ketone bodies in what? Your type 1 diabetics, not your type 2. Interprofessional care. So what are we going to do for these patients with the HHS? HHS is a medical emergency and it has a high mortality rate. The management of DKA and HHS, they're similar. They both include, look at this, immediate, right away. That is your priority, IV administration of insulin. We have to get that blood sugar down, okay? Immediate IV administration of insulin, and either your normal saline or your half normal saline. HHS usually requires large volumes of fluid replacement. And we know that because we know one of those triggering factors was that patient just having a history of not drinking enough fluids, or risk factor, someone who doesn't drink enough fluids, such as the older person with diabetes. This should be accomplished, look at this, slowly and carefully. Our HHS patients, how are we giving them the fluids? Slowly. Patients with HHS are commonly older. They can't handle fluids hard and fast. Remember, the HHS are usually the diabetics over 60. Patients with HHS are commonly older and may have cardiac or renal compromise, requiring hemodynamic monitoring to avoid fluid overload during the fluid replacement. So that is a big difference in our treatment of DKA versus HHS. When the blood glucose levels falls also to 250, the IV fluids containing dextrose are going to be administered as well. Same reason, if their blood sugar drops too low, let me back up. If the blood sugar drops low too fast, it could cause cerebral edema. And that cerebral edema can cause the patient to go into seizures, coma, and a list of other stuff. Okay. Electrolytes are monitored and replaced as needed. Hypokalemia is not as significant in HHS as it is in DKA. Although fluid losses may result in milder potassium I can't speak. I get excited and I get tongue-tied. Let me back up. So hypokalemia is not as significant in HHS as it is in DKA, although fluid losses may result in milder potassium deficits that require replacement. So because that patient's getting insulin, yes, it may cause the potassium to drop, but it won't be as significant. It won't be as much an assault on the body in HHS as it is in DKA, okay? You will assess for signs of potassium imbalance resulting from hypoinsulinemia and osmotic diuresis. When insulin treatment's begun, serum potassium levels may decrease rapidly as the potassium moves into the cell once insulin becomes available. We know this. They said this to us a million times. This movement of potassium into and out of extracellular fluids influences cardiac functioning. And you know that. What does potassium affect? The heart. Cardiac monitoring is useful in detecting hyperkalemia and hypokalemia because characteristic changes indicating potassium excess or deficit are observable on the ECG. So you better believe that patient is going to be getting continuous insulin. They are going to be on a heart monitor. They're going to be getting ECG tracings. Now that we've gone over DKA and HHS, now we can go over the differences. Let's look at the management. Oh, look at this, guys. I could have done this table already. They didn't even give you the differences in management. They just put it together. But anyway, I'm so happy I covered both first. So management, Priority, IV fluids. Let me write priority here. IV fluids. You want to give IV administration of short-acting insulin, get that blood sugar low. You want to do electrolyte replacement, because you see what happens with a patient who has diuresis, all of the electrolytes go with it. You want to assess their mental status. You can make sure you take looking at the INO. Excuse me. Because one of the fastest ways we know that patient's getting better is we see the urine output start to increase. We know that the kidneys are starting to do better, because let me tell you something, those kidneys will shut down and they will not reopen until the patient's fluid volume starts to be increased, okay? You're going to monitor the blood glucose levels, do ECG monitoring, assess the cardiovascular and respiratory status. Okay, this is the last thing I'm going to go over with you before I let you go, because I've gone over my time, way gone over my time. Let's talk about emergency management for DKA. That's our type 1 diabetics. Again, look at those signs and symptoms: the dry mouth, the thirst, the fruity odor on their breath. Okay, those are the ketones you're smelling. Weak rapid pulse, urinary frequency. They're trying to get all that sugar out of the urine. Serum glucose being higher than 250. We're seeing glucose in the urine and ketones in the urine. Let's talk about interventions. You want to make sure the patient has a patent airway, because who cares about anything else if they're not breathing, right? You want to make sure that you give them fluids with, look at this, a large bore catheter. Why? Because we're giving them fluids hard and fast. Normal saline, regular insulin, but make sure once we get that patient's blood sugar down to 250, we're going to add dextrose to the saline that they're getting, so that their blood sugar doesn't drop too fast and that they don't get cerebral edema. We're going to assess breath sounds. Professor D, why are we assessing breath sounds? Didn't I just tell you we're giving the patient fluids hard and fast? What if we give them too much fluids? Where are the fluids going to go? Into their lungs? Are we ever supposed to hear crackles? Are they supposed to have dyspnea? No. So we're going to be listening to those breath sounds to make sure that we haven't put them in the fluid overload, to make sure that fluid hasn't spilled over into their lungs. We're going to be checking their glucose, obviously, but also the potassium, because we know that insulin can drop their potassium. We're going to administer potassium to correct hypokalemia if necessary. And something you guys also need to recognize, all of that fluid that we're giving the patient, right, that can dilute the little bit of potassium the patient does have. So definitely we need to watch for potassium. We're going to administer sodium bicarb if the patient has severe acidosis. And that severe acidosis, that's our pH dropping to less than 7.0. Remember, normal is supposed to be 7.35 to 7.45. And last, we're going to add dextrose to the IV fluid for blood glucose levels less than 250. What did I write here? To prevent dramatic decrease drop. And that is your part 5 of diabetes. And believe it or not, I think there's still so much more. That's why you guys have so many questions on diabetes. So for part 6, guys, we're going to start on hypoglycemia. But for this video, please sound off in the comments. Let me know what you thought about this video. Let me know if there's anything you'd like to see me cover that I haven't covered yet. If you'd like me to do more questions, you know those questions that I do on Sundays. If you'd like to me do more questions, let me know. Just sound off in the comments. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. And you guys can find me and practice more questions with me during the week on TikTok, Instagram, and Facebook. Thank you so much for watching this video, and you'll see me on the next video.